Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. And let's welcome today's speaker with great honor, none other than Dr. P.M. Gopinath sir. And let me share some of the achievement of sir. Sir has done MBBS, DGO, MD, and Director and Syrian Consultant at the Department of OBGY at Institute of Obstetrics and Gynecology and IVF, Chennai. And today sir is going to speak on a topic planning a delivery in Preeclampsia on the eve of World Preeclampsia Day. To know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Good evening, everyone. It has been an honor to be on the platform of the most prestigious leader, medical in the medical field. So again, a topic which was given to me is preeclampsia, which I am quite happy about it because this is the one which is the current scenario. A lot of challenges are there. So let us see one by one. So this is the most common medical complication in pregnancy. Approximately about 7 to 10% of all pregnant women have this. This is associated with maternal and perinatal morbidity and mortality. So there was a survey why mothers die in Kerala in the second edition, where actually around 12% of the maternal deaths are due to the hypertensive disorder. Second most common cause of the mortality. So if you track the various causes of maternal deaths right from 2004 to 2009, you see hemorrhage has come down from 20 to 10%. Heart disease is more or less static, whereas sepsis has again slightly increased. But if you look at the hypertension, it was 15.1 and now it is around 19%. So this is the magnitude of the problem in terms of the maternal mortality. Why there is a issue? There is a delay in diagnosis, delay in initiative definitive treatment, suboptimal management, delay in referring to the tertiary care centers there. The classification, normally we just say gestational hypertension, preeclampsia and eclampsia, chronic hypertension, preeclampsia superimposed on chronic hypertension. So this is following the American Congress of Physicians and then National High Blood Pressure Education Program. What is hypertension in pregnancy? It should be more than 140 millimeters or 90 millimeters of diastole. It should be confirmed by about two or more readings, 4 hours apart, but not less than 7 days. A BP of 160 by 110 reconfirm early and then start the treatment. A diastolic of the previously what we used to say diastolic of 30 millimeters, systolic of 30 millimeters, diastolic of 15 millimeters above the pre-pregnancy is no longer a criteria. PIH is a term which is not being used today. What are the risk factors here? Prima gravida, yes. Age less than 18 and more than 35 years. And look at the race. There are some Asian races, it is quite common. It is high BMI, they are included into it. Past history of eclampsia, preeclampsia and eclampsia, and family history of preeclampsia, diabetes mellitus, hypertension, renal diseases, Apla syndrome, polycystic ovarian disease, connective tissue disorder, adding to all this pregnancy complications like multiple pregnancy, RH isoimmunization, and iodide form mole. So the causes, exact cause is not known. Maybe it's just a stress response. Mild to moderate PAH remains untreated or probably controlled with therapy there. The physiological changes, what actually happens is very significant. There are a lot of changes in the CV and renal mechanisms to meet the metabolic needs of the mother and the baby. What are the factors? When you just see, there are some factors increased during pregnancy, there are some factors decreased during pregnancy. Cardiac output is increased, maternal blood volume is increased, renal blood flow is increased, GFR is increased, renal concentration, renin activity are increased. The total peripheral resistance is reduced, blood pressure is reduced. These are all normal physiological changes which takes place. The physiological changes in the blood, there is a vasoconstrictor factor, there is a vasodilatation factor. Endothelin, thromboxane, angiotensin 2 are the vasoconstrictive factor. Vasodilative factors are nitric oxide and prostacyclin. In normal pregnancy, the vasodilators are increased, vasoconstrictors are reduced to increase the blood flow. However, this mechanism does not occur with PIH. There are some changes in the early pregnancies. Invasion of the extravillous trophoblast remodels the maternal spiral arteries and displaces the smooth muscles and endothelial cells to produce the blood vessels with a larger diameter with an increased blood flow and lower resistance. This is a vital step in the blood pressure requirement in pregnancy. See, here you will see on one side there is a creation of a high flow and a low resistance, but you will see here the endothelial wall becomes thin and modified. Whereas if this does not occur in case of PIH, the wall becomes thicker here, just like as I have shown them. The placental ischemia, the decreased uterine blood flow, there is a placental ischemia, and placental release of factors are increased. So, based on all these things, there is a renal pressure, nutrients, natriuresis takes place. There is an increase in total peripheral resistance, resulting in hypertension. So, in normal pregnancy, you also have a combination from arachidonic acid, you get an endoperoxidase. So, it produces prostacyclin and thromboxane. The balance is maintained because prostacyclin has got some specific actions like vasoconstriction action. And here the thromboxane has got a reduced vasoconstrictive action. So, here what you will see here, in case of preeclampsia, there is a tilt between the prostacyclin and thromboxane. Thromboxane is reduced, which increases the vasoconstriction, platelet aggregation, reduced uterine activity, and uteroplacental blood flow. So this leads into the PIH there. If you look at that vessel wall, the maintenance of the vessel wall, you will see with the VGF and PLGF there. So this is the changes which take place in the vessel wall. It becomes thinner. You see the placenta and the blood vessels there. The flow increases in the normal pregnancy. However, with eclampsia, the flow decreases in the eclampsia there. There are a lot of mechanisms with which angiotensin acts on the liver, the kidneys, brain, and then the peripheral thing. So this particular issues all put together is altered. Now, how do we know which one is going to get a preeclampsia? Once when they get a preeclampsia by way of increase in blood pressure, then your problem becomes simple to direct them. But however, our main aim is to predict the model. So the angiotensin infusion was used at about 8 nanogram per kilogram per minute, and the positive predictive value was only between 20 and 40%. The mean arterial pressure, the MAP, was taken as a diastolic blood pressure plus systole minus diastole. So 2 times that, when they've just seen it, again the positive predictive value was lower. very conventional. Those days when we were students, we used to do the rollover test. You make the patient sit upright or lie down upright and take the blood pressure, put them on the left lateral side, wait for about 5 minutes, take the blood pressure, put them back again, and just see that. So this rollover test was found to be very effective that time. So there are some other markers like urinary kallikrein excretion was reduced, fetal fibronectin was increased, Doppler velocity of the uterine artery was seen and at around 18 weeks, and it was repeated at 25. Another newer entity is placental growth factor called PLGF. It was synthesized by placenta and has a potent angiotensin function. It is decreased in pregnancies that develop PE. The normal level is somewhere between 200 milligram to 600 milligram. When you see it is less than 200 milligrams, most of the times they do about 80% of the time they develop preeclampsia. The levels again depends on the maternal factors and the machine used for the measurements there. We have used the maternal placental growth factor in the prediction of preeclampsia in a significant in assisted conceptions there. This paper, we have just published it in 2019, where we have taken about 189 women with IUI and ICSI conception at around 11 to 20 week size, and then the outcome was the onset of preeclampsia and eclampsia. There was a significant association between the low PLGF and the onset of the preeclampsia and growth restriction. So the same paper was also published in the Fertivision 2019, where we used this particular model to predict the onset of preeclampsia, especially on the oocyte donors. Here, PAP-A is another important enzyme which plays a role in the placental growth and development. It is reduced in moms in fetus with trisomy 18, 13, and 21. The performance of this screening improves when combined with PLGF. There is another substance, serum soluble FMS like tyrosine kinase. It is called SFLT1. So this is an anti-angiogenic factor that plays a vital role in the pathogenesis of preeclampsia. In normal pregnancies, it is dependent on the maternal factors and the machine used again. It is increased in the established preeclampsia, but useful at later gestation, especially after 22 weeks size. So if you look into the Fetal Medicine Foundation, screening for preeclampsia and fetal growth retardation, we take the maternal history, prior risk is there, add the biophysical markers, and then add the biochemical markers, then give an adjusted risk, and that will tell you what is the chances of that patient doing it. This can be taken at around performance of screening at 11 to 13 week size. So at that particular gestation, you can put into the mean arterial pressure, PLGF, all put together a positive predictive value at 34 week size, at 37 week size, at 39 week size from the detection rate when you can start doing it from 11. Again, when it will become 24 week size, the same thing when you just see, you will see that there is an improved efficacy as per this NHS schemes there. This screening can also be done between 30 and 34, where at 37 and beyond, it is only 55% efficacy there. So there are two types of preeclampsia. One is a non-severe, where it is flitting and fleeting between 140/90 and 160/110. Severe is when it is more than 160/110, it is severe. Preeclampsia is about 15 to 25%. Eclampsia is 5%. IUGR, prematurity, increased perinatal mortality. Prognosis is good in non-severe, which develops after 36 weeks size. The preeclampsia is a new onset of hypertension that develops after 20 weeks of gestation with new onset of proteinuria, which was not present earlier. So there is a spot urinary PC ratio of 0.03, zero point 0.3 or 30 milligrams of per deciliter of protein, or plus one dipstick in sample. In order to do, there are two are not available. Hypertension, proteinuria, edema is no longer a consideration. So it is not three, it is usually with two. Classification, as we have mentioned it earlier: non severe preeclampsia, severe preeclampsia with symptoms, and then early onset, less than 34 week size, late onset, more than 34 week size. It is a new non neogenic preeclampsia, then angiogen preeclampsia. There are criteria for severe preeclampsia: 160, 110 and above, headache and visual symptoms, epigastric or upper quadrant pain, thrombocytopenia, elevated liver enzymes, more than 1.1 of serum creatinine, and pulmonary edema. IUGR, proteinuria of more than 5 grams are no longer a consideration to cause that as a severe preeclampsia. In the absence of proteinuria, preeclampsia also be defined as the new onset of hypertension with other signs of end organ involvement like thrombocytopenia, renal insufficiency, impaired LFT, and cerebral visual systems there. What is the goals of our management in preeclampsia? Early identification of worsening of the disease, close fetal and maternal monitoring, appropriate timing of the delivery, appropriate mode of delivery. If you look at the management of normotensive pregnancy who may develop subtle signs of preeclampsia, so there may be an excessive weight gain, and epigastric pain may be there, and BP if it is more than 140/90, and sometimes there may be a visual. What do? We initially, when we detect them, and we can detect and then review them after 1 or 2 days, and we can always, if there is an excessive epigastric pain, we can do a CBC and a platelet count and LFT and serum creatinine. When there is the BP is more than 150 plus visualize, we have to hospitalize them and then look for evaluation. So in a non-severe, that is a mild preeclampsia, what do? We hospitalize, measure the blood pressure, and then look for the symptoms of preeclampsia. Fetal monitoring is done on a regular basis with NST and modified biophysical profile, and restricted activity, and antihypertensives is to be started when it is BP of more than 150/90. Absolutely no corticosteroids. So there is no maternal fetal compromise. We take them up to deliver at 37 week size. If there is a maternal fetal complication, even before 37 weeks, we deliver them. In case of severe preeclampsia, we hospitalize, start them on antihypertensives like magnesium sulfate, steroids if it is less than 26 to 34 weeks old, check the BP, urine protein, signs and symptoms of preeclampsia, and then evaluate and look for the mother and the fetus about the abnormalities and then manage accordingly. In the subsequent management, in case if there is a high persistent elevation of the BP with the cerebral symptoms, pulmonary edema, and you have to immediately deliver them. And if no, then probably look for all the other symptoms, and we can add corticosteroids about 40 and deliver after 48 hours of the corticosteroids. Expected management: discontinue the magnesium sulfate, continue with the antihypertensives there. And in maternal and fetal complications and PROM, you have to deliver them. So if everything is normal, you deliver at around 34 week size for severe preeclampsia. There is another entity called preeclampsia superimposed on chronic hypertension. It is a new onset of proteinuria, worsening of already existing proteinuria, and then features of multi-organ involvement, usually occurs in early pregnancy, less than 20 weeks. Hypertension is very severe. It is associated with IUGR and high perinatal mortality and morbidity there. So there is atypical preeclampsia. The management is one. It can be a gestational proteinuria with one or more of the following: thrombocytopenia, elevated liver enzymes, and hemolysis, and symptoms of severe eclampsia, which can occur before 20 weeks or within 1 month postpartum. There. Now, how do we manage these cases only with the hypertensives and preeclampsia? So, according to the Cochrane review, use of hypertensives is not going to prevent preeclampsia. High risk of hypertension only needs antihypertensives. BP of more than 160, 110, you need it. Target or then damage is expected. An age of more than 40, multifetal gestation, diabetes mellitus, stroke, preeclampsia, and then perinatal loss, you have to do it. So CHIP study recommends antihypertensives for mild to moderate to preeclampsia as well there. What are the antihypertensives we use? What is the objective? It is to prevent hypertensive crisis, CVA, LVF, eclampsia, pulmonary edema. To prolong the gestation as much as possible to get the fetal maturity for survival, to improve the perinatal survival. The targeted BP are severe, you target them between 140, 80 to 150, 100. If it is a super added, then you have to just maintain it around 140 to 90 there. So the common antihypertensives first line of therapy is labetalol, FDC category C. About 200 to 1200 milligram per day can be given in 2 to 3 divided doses. It is well tolerated. Potential bronchoconstrictive effects you have to anticipate. Methyl dopa, alpha methyl dopa, about 20 years ago, that was the kingpin in the management of pregnancy-induced hypertension. But today, the first line is the labetalol. So this is about zero point 0.5 to 3 grams per day can be given. Some concern with the depression, hepatic disturbances, hemolytic anemia, and it does not lower that. The second line of drugs, nifedipine, 10 to 30 milligrams per day, verapamil, 80 milligrams GDS, clonidine, 0.1 to zero point 0.6, and hydrolazine hydrochloride, about 25 milligram. Everything has got a risk. If you look at that labetalol, it is an alpha and beta adrenergic blocker, antioxidant effect. Uteroplacental flow is sustained even though that there is a reduction of BP. That is the most important point you should consider. More effective in reducing albuminuria compared to nifedipine and alpha dopa. If you look at the pharmacodynamics, labetalol, it is a selective alpha and beta blocker and vasodilatation, potential reduction in the peripheral results. And it is also a non-selective beta blocker. It protects the heart from the reflex systemic defect there. So that is the important part. It is eliminated in about 5.5 hours. It is metabolized in the liver, excreted via urine and bile into the fetus. Protein binding is 50% there. This is the overall algorithm for maintaining the labetalol. Let's just take it bit by bit. When we try to use it, we can shift it from IV to oral. Once when the patient is controlled with certain amount of labetalol IV, oral can be started with about 100 milligram BID with tapering IV doses as required. The dose of labetalol should be titrated again. If there is a slow infusion, can add about 40 ml of labetalol, that is 10 ampules in about 160 ml a slow IV fluid. This fluid should run by about 1 milligram per ml or probably 40 milligrams of labetalol in about 10 ampules and 250 ml IV fluids. The resultant solution should contain 200 milligrams of labetalol in 290 milli solution. That is approximately 2 milligram per 3 ml. Should be the solution. So commonly used are dextrose and sodium chloride, IV infusion, but the dose should be individualized there. So begin the treatment with 20 milligram per hour. Observe for about 30 minutes. If the BP is not controlled, you can go up to 40 and then observe for about 30. If the BP is controlled, then continue with the same 40. If the BP is not controlled, then you go up to 80 and then you can continue with the 80. So if the BP is still not controlled, increase up to 160. Up to 160, you can just go in this particular titration there. So, what about the effects of the transplacental? There is a resistant index is just comes down. So, there is no deleterious effect on the uterine artery blood flow despite the control of maternal BP. That is more than 85% of the cases maintaining the normal uteroplacental perfusion of the fetal oxygenation there. What are the contraindications? Bronchial asthma, overt cardiac failure, greater than first degree heart block, cardiogenic shock, severe bradycardia, history of hypersensitivity to any component of this particular product, and history of obstructive airway disease. The other options are nifedipine, a calcium channel blocker, rapid action, 10 milligram every 30 minutes orally, followed by 10 to 20 milligram every 6 to 8 hourly. Side effects are hypotension, tachycardia, and water retention. The vasodilatory effect of hydralazine, 5 to 10 milligrams every thing. Maximum dose is about 30 milligrams. Aprasol, 25 milligram TDS is also being tried. Alpha methyl dopa is generally used in about 500 milligram, 250 to 500 milligrams orally, and maximum is about 2 grams thing. There is a delayed action, and probably these patients might go in for a postpartum psychosis and mild hepatotoxicity. Alternatively, clonidine 0.1 to 3.125 can be used in hypertensive crisis. Nitroglycerin and nitroprusside infusion is also used in the thing. There is a word of caution when we try to use the anticonvulsant therapy, magnesium sulfate. Obstetric indications are severe preeclampsia and eclampsia, HELP syndrome, preterm labor less than 32 week size in order to have a brain protection. And mechanism of action, it is a central anticonvulsant action, peripheral courier-like action, prevention of calcium reflux, and at the myometrial junctions there. It is equally effective as IV and IM. Toxicity are respiratory depression, renal failure, and cardiac arrest. Effect on the fetus, loss of variability of the fetal heart there. So intravenous regime, loading dose is about 4 grams in 100 ml of diluted IV, administered over about 15 to 20 minutes. Maintenance, 1 gram per hour IV infusion. Intramuscular regime, 4 grams of 20% solution in about a loading dose of 20 minutes, 10 grams of 50% solution in 5 grams in each buttocks, deep intramuscular. It should be mixed with a small amount of 1% lignocaine. And maintenance therapy, 5 milligrams or 5 grams of 50% solution every 4th hourly on alternate buttocks. What do we monitor? We have to look for respiratory rate, patellar reflex, and urinary output. So how far you can just go? You will see here, in normal pregnancies, the magnesium results, the levels are 1.5 to 2.5. Therapeutic level for the seizure prevention is 4 to 8. When it goes between 9 and 12, there is the loss of patellar reflex. When it goes between 15 and 17, there is a muscular paralysis and respiratory arrest. When it goes beyond 30, then there is a cardiac arrest. Absolutely no need for a routine serum magnesium in estimation. When we titrate the correct dose, it should be good enough. It is only for your knowledge. The HELP syndrome, where there is a hemolysis, elevated liver enzymes, and low platelet count, it is not all preeclampsia land up with the HELP syndrome. Only about 5% of the times it comes there. It is roughly around 2 to 12%. 80% is associated with severe preeclampsia and eclampsia. Symptoms are epigastric and right up upper quadrant abdominal pain, nausea, vomiting, viral infections like symptoms, and history of malaise. So you have to differentiate it from acute appendicitis, cholecystitis, and pyelonephritis. And management should be in a tertiary care. You cannot manage in the secondary care thing. It has to be sent to the educational institution. Initial management is same as that of preeclampsia. Maternal condition is assessed and stabilized, and anti-seizure prophylaxis and antihypertensives. Correction of DIC if it is present. Fetal well-being is by NST and BPD and SUSG. HELP syndrome, no rule for expected management. The moment it comes through, you have to give a corticosteroid if it is less than 34 week size. High dose dexamethasone is not recommended, and delivery is the definitive treatment. And labor may be induced in following cervical ripening, cesarean section for obstetric indications, intramuscular injection, parental block, and spinal and epidural anesthesia must be avoided there. There are some points to remember. Gestational hypertension is equally important as the preeclampsia. Preeclampsia is a syndrome of gestational hypertension and the end organ dysfunction. Presence of hypertension and proteinuria are diagnostic of preeclampsia, but their absence does not rule out it. That is the most important thing. The atypical preeclampsia in gestational hypertension or gestational proteinuria with one of the symptoms of severe eclampsia, hemolysis, elevated liver enzymes may be present there. And the atypical preeclampsia can present as capillary leak syndrome without hypertension or proteinuria. Early onset IUGR may be the primary manifestation of preeclampsia. Postpartum hypertension can be persistent or de novo. Eclampsia, HELP syndrome can occur in the first trimester, first time in the postpartum without prior hypotension. Labetalol is the antihypertensive of first line of treatment, both hypertensive crisis and maintenance. Severe preeclampsia and eclampsia should be referred to the higher center for a parental antihypertensive thing. So, in nutshell, the eclampsia can occur by about 5 to 10% of the cases. There are some new indexes which has come out for the prediction starting of low dose aspirin to maintain and to prevent the onset of eclampsia. If it does, we have wonderful drugs with that. We can early diagnose it. We can take them up to 37 weeks and deliver. In case of severity, then probably you might have to take a call to deliver them early. There is no necessity to run for a cesarean section. Cervical ripening and induction can be tried. In case if there is another obstetric complication, then probably you can land up with the cesarean. Thank you very much for your patient listening. Hello, hello.
Thank you so much, all the audience, for joining this webinar and making this webinar informative one. As Sam has some technical issue, he will be joining us in any moment. I request all the participant, if you have any question related to this topic, you can put it in a comment box. One by one, I will take these questions once Sir join this session. Thank you so much, sir. There was some issue with the network, sir. It got disconnected. Sir, we have received some questions, sir. With all your permission, shall we take these questions?
Sure, sure.
The first question is from Dr. Agarwal. He is asking how might future advancement in personalized medicine impact the management of preeclampsia?
See, there are two focuses. One is in the prediction model, second is in the treatment module. Lot of advancement is being done on the prediction model. So in the treatment model as such, it is only the antihypertensives and then maintenance of the pregnancy up to 37 weeks. So a lot of improvements are there. Besides what all I've just mentioned it, there are a lot of other prediction models have come. So with that, you will be able to definitely have a good prediction and prophylactic use of the low dose aspirin that will reduce the incidence of preeclampsia.
Thank you so much, sir, for answering this question. I hope that doctor has received his answer. Another question is from Dr. Shruti. She is asking, how should preeclampsia be managed in women with pre-existing hypertension or other comorbid conditions?
Yeah. Actually, this is quite an interesting question. So, when you can have preeclampsia on renal diseases, preeclampsia on liver diseases, preeclampsia superimposed on hypertension, the management practically just the same. If there is a complication along with that, you might terminate between 34 and 37 week size. So maintain with the hypertensives. Do not use steroids because they will be having a high circulating level of corticosteroids that will automatically trigger the pulmonary maturity. So you can use the magnesium sulfate for prevention of the CNS uh, abnormalities, CNS prevention, protection between by around 34 week size with about 1 gram per day per hour for 1 day. So with that, you will be able to take it out. So if you take in terms of a preeclamp, the max self management, even in renal failure, we can use it. Recently, I had a patient who has a renal transplant, advised not to become pregnant. She has become pregnant and come back at around 28 week size, and there is a rejection of the transplanted kidney. So her renal parameters were worsening. Her liver has also started doing a kind of a dysfunction, and we managed it. But I wanted to use a Maxilf on her for the, because it is only around 28 to 30 week size. When we were referring through the journals, so whatever we are using it, we can use it with about half the dose. So loading dose will be only 2 grams and maintenance dose will be half a gram. And every fourth hourly we have to measure max self. When it crosses 6, then we might have to stop the max self. See, we managed like this, took her up, and then did a section, and then delivered the baby, and then the mother is on dialysis now. She is dependent on dialysis because it's a rejection, but we were able to salvage the baby.
Thank you so much, sir, for sharing your insight on this question, sir. As I can see, sir, there is no more questions, sir. With all your permission, shall we conclude this session for today?
Thank you.
Okay, sir. Welcome, sir, and take care of yourself, sir. And with all your permission, we are closing for today. And we would like to see you in future also with different topics, sir. Have a great day, sir. Thank you.
Thank you.
Welcome, sir.